So we will welcome Dr. Elsayegh and Kenny Raymond, and they are going to talk to us about CMT-related breathing issues.
My name is Dr. Elsayegh. I work at Cedars-Sinai in Los Angeles along with Dr. Pfeffer, who's a great surgeon. I know him well. We work very closely together. I've had the honor of giving many of these talks with the CMTA, and it's always a pleasure. And, every now and again, someone will thank myself or Kenny for giving this talk because they always learn something new, and it somehow changes their life as well. All right, so clinical features of or pulmonary features of CMT. Number one is diaphragm dysfunction. Number two is mentioned. Perfect. All right. Number two is mentioned several times, scoliosis. Now, scoliosis, of course, affects the orthopedic part of CMT. It affects the hips. It affects the spine. It affects the way these patients walk. But for me, it also affects the breathing later on in life. So that's very important. More in children than adults, but vocal cord paralysis, and then finally sleep disorder. We get questions about all of these all the time. And due to time, and I really want Kenny to speak because he's excellent, I'm going to try and rush through my talk a little bit just so we can make it on time, and then any questions we can always answer later. Very quickly, the breathing issues with any neuromuscular disease, including CMT, is really the respiratory muscles. It's not so much the lung, and it's not really the lung at all. It's more the respiratory muscles. And the respiratory muscles are muscles just like any other muscles in your body, and they're innervated by nerves. And if the nerves that affect the feet or any other part of your body is affected, well, the nerves that affect your breathing can also be affected. The main muscles that we use in breathing are your diaphragms, and the diaphragms are innervated by the phrenic nerves, which run on both sides of the chest. Again, I'm going to go a little bit quickly through some of these slides. So when the phrenic nerves are affected, your diaphragms can become weaker, and that can show early signs of respiratory issues with CMT. I want to make a very important point here before we continue, because I've heard many different opinions on this. In general, breathing is not very common. Breathing problems are not very common with CMT patients. That does not mean that it does not occur, okay? And we think it's probably more common than we think. So a lot of times, please, when you go see a pulmonologist or you go see your neurologist and they diagnose you with CMT, a few years later, you have respiratory issues, and then you go see a pulmonologist. Unfortunately, like Dr. Pfeffer mentioned, a lot of these doctors have never heard of CMT, or if they have, they've seen 1-2 people patients in their entire career. So they always will blame it on something else. They're going to tell you have COPD, and you're like, I've never smoked. Well, then it must be asthma. Well, but I've never had asthma. And you just keep going in circles and you get nowhere. So it's very important to understand that although it's not the most common issue in CMT, it can occur. So some of the early signs of respiratory dysfunction. Really, again, it's anything that affects the diaphragm. So what we notice a lot of times is when patients lay flat, so upright and walking around, they're completely fine. And then at nighttime, I say, oh, how do you sleep? Well, I sleep on a wedge. I sleep on 3 or 4 pillows because I'm more comfortable that way. Well, a lot of times you're more comfortable that way because the higher up you're sitting, the gravity will pull your diaphragm down. So if your phrenic nerves are weak and your diaphragm is weak and you lay flat, you're not going to be able to breathe as well. So sitting in a more upright position, the gravity will pull your diaphragm down, and you can take bigger, deeper breaths, and you feel more comfortable. How do we diagnose? A lot of these slides I've changed over the years from questions that I've gotten from a lot of the people that attend the conferences. So I'm trying to fit as much as I can in a short period of time. But how do we test for this? Pulmonary function testing is a great source of testing for respiratory muscle dysfunction. Now, does everyone need a pulmonary? Is this a mandatory requirement? No. If there are any signs of respiratory issues, I recommend pulmonary function testing. From that point on, you don't need it every single 3 months or 6 months or year, what I like to do is get a baseline pulmonary function test on any of my neuromuscular patients, including CMT. After I have that, with CMT, because again, respiratory is not the main component of it, I'll check just a spirometry, just 2 tests, forced vital capacity and a negative inspiratory force every 6 months to make sure that there is no decline in either of those. We just mentioned that. The other thing that we can look for in diaphragm dysfunction is what's called the sniff test. You stand in front of an x-ray and you sniff basically, and we watch your diaphragms move up and down. You can either have bilateral weakness, you can have complete paralysis where it's not moving at all, or you can have unilateral, one-sided weakness or paralysis. Finally, phrenic nerve EMG, which is, from what I understand, quite painful, and most people don't like it, but that is another way of testing to see if your diaphragms move and if your phrenic nerve is working well. So we've mentioned you can either have bilateral or unilateral, either weakness or paralysis. And then you have to remember, and I think one of the neurologists from Denver mentioned this earlier, is you go to 2 extremes. You can go to a physician and a respiratory a pulmonologist and say, I'm short of breath, and they'll never blame it on CMT. They say, no, it has nothing to do with CMT. And then the other extreme is you'll go and they'll blame everything on your CMT. But you have to remember that, CMT patients live a completely normal life otherwise, and a normal lifespan, and they can have other issues. So unilateral diaphragm dysfunction is more likely to be caused by other issues that may have occurred, whether it's trauma, car accidents, previous surgeries. And I caution you with this is once they start blaming, or once everyone starts blaming everything on CMT, it's never good. I've had patients come in and say, oh, I have crushing chest pain. This is just because of my breathing with CMT. I'm like, no, crushing chest pain is crushing chest pain. And you have to look at the heart, and you have to look at other things that may be going on. So just be very careful. How do we manage this? With respiratory muscle dysfunction, my recommendation is always non-invasive ventilation. There are really 3 devices out there right now. So one question that I always have is CPAP sufficient for respiratory muscle dysfunction? And the answer is no. The caveat to that is if you have absolutely no respiratory involvement at all, but you have sleep apnea, pure sleep apnea, CPAPs are sufficient for that. Anything more than that, I recommend either going to something called a BiPAP or a non-invasive ventilator. And very, very quickly, what is the difference? CPAP is, what it stands for is continuous positive airway pressure, which means that this machine, I'll show you what, sorry, I don't know how to go backwards. There we go. Okay, so I don't have a picture of the CPAP, but basically it's a machine that you wear with a mask while you're sleeping. And continuous positive airway pressure, it gives you a pressure, whatever that pressure may be. Let's say it's a pressure of 12 millimeters of mercury, 12 centimeters of water that's being pushed into your throat. And with sleep apnea, the point of obstructive sleep apnea is that your throat closes down. So any kind of pressure will stent your throat open and it relieves the sleep apnea. Well, when you're breathing in, it gives you a pressure of 12. When you're breathing out, you have to fight against the pressure of 12. So when you have respiratory muscle weakness, it's very, very difficult to fight against that high pressure when you're breathing out. And it actually makes things worse. First of all, it's uncomfortable, but second of all, it actually increases your carbon dioxide even more, which is the main issue with respiratory muscle dysfunction in CMT. So what is BiPAP? BiPAP just stands for bilevel positive airway pressure, meaning that we give you a pressure when you're breathing in of, let's say, 12. When you're breathing out, we lower it to 4 or 5 or 6 or whatever that may be. That becomes more comfortable. And that works pretty well for respiratory muscle dysfunction. However, what's even better than that are these devices, which are non-invasive ventilators. Again, I just took a random picture of one of the 3, and from what I understand, this one is not going to be made anymore. So the 3 devices out there are Trilogy, Astral, and another device called Louisa, which is new. The Trilogy, from what I understand, they're not going to make them because of the issues with the company. But we still have the Astral, we still have this, Louisa. And, I recommend that we go to one of these. They're much more comfortable for you. Patients like them a lot more, and they treat the underlying problem, which is the respiratory muscle weakness, and they lower your carbon dioxide level, which is the most important thing in all of this. So this slide I throw in, because this doesn't apply to 99% of you, but there is that 1% that it does apply to. If respiratory muscle dysfunction is one of the main problems that a particular patient has, number one is I recommend using the non-invasive ventilator at nighttime while you're sleeping for two reasons. Number one is it treats sleep apnea, which a lot of neuromuscular patients have, including CMT. And then number two is it doesn't disrupt your day. You're not forced to sit there during the day. You can go about your day doing whatever you do. And then while you're sleeping, you use the device. If that does not enough, then we move on to using it more hours during the day in addition to night. Eventually, and rarely in some patients, they end up using it 24 hours. Then we have to talk about something a little bit more invasive, such as a ventilator with a tracheostomy. Now, I want to mention this, although, again, 99% doesn't occur in CMT. Kenny or I always get that 1% that asks us those questions that do have a tracheostomy and are on invasive ventilation. This is what a tracheostomy is. The good thing about this is now, before, 20 years ago, if patients had a tracheostomy, they end up in a nursing home. Now they live at home, completely normal lives, because the same non-invasive ventilator we can now use invasively. So instead of a mask, you just hook it up to the tracheostomy. It's portable, and they can live their life as normal as possible. I want to very quickly talk about this because I always get this question. Diaphragm pacemakers. Not all centers do it. My center does it. At Cedars, diaphragm pacing is one of the newer technologies out there for diaphragm weakness. I want to start off by saying that it's the results in neuromuscular disease are equivocal at best. Some studies have shown mild benefit. Some studies have shown harm. Most studies have shown that it doesn't really make a difference. So I want to mention it because I always get this question. So in general, we don't use diaphragm pacemakers for neuromuscular disease anymore, unless in very, very specific situations. So my recommendation is always go to a center that has experience in neuromuscular disease to talk about diaphragm pacemakers. We still do them, but more for spinal cord injury after car accidents or other spinal cord injuries. But basically what a diaphragm pacemaker is this is what it is. It's an external device. We go into the abdominal cavity. We make sure that your diaphragm is still being innervated somewhat by the phrenic nerve. We implant two wires on each side near the phrenic nerve to further stimulate the diaphragm and have it contract. It's an external device, so you have what looks like a little computer flash drive that comes out of your body, and the device gets connected to that external piece. Okay, and then we mentioned unilateral diaphragm paralysis. A lot of patients will come more likely to me with unilateral than bilateral diaphragm dysfunction. In these patients, we also do have something to help, and it's called diaphragm plication. First, we try the non-invasive ventilator, and when that is not enough, we can always do what's called a diaphragm plication, where we take the diaphragm. In diaphragm paralysis, your diaphragm will move up your chest. So it looks like this on the left side, where the diaphragm is up halfway up your chest. What we do is we take the diaphragm, we pull it down, we suture it in a lower spot where it's supposed to be, and then the other image is a post-plication image where, as you can see, both lungs are now extended and open, and patients breathe a lot better. The next issue with CMT and with respiratory muscle dysfunction is a lot of patients will have diminished cough, a weakened cough, because the weaker or the harder it is for them to breathe. Again, you use your respiratory muscles for coughing, the more difficult it is to cough and excrete your secretions. So you have to, your physicians, please be wary of that and talk to your physicians about it. If you just can't, if your cough is not as forceful, I'll get coughing becomes weaker. I'll hear sneezing becomes weaker. And this is important because what ends up happening is you will have mucus plugs. So you'll build up mucus in your lungs. We all have mucus in our lungs. We just take it for granted. We just cough every now and again, or we sneeze or clear our throat. But what we're doing is we're mobilizing these secretions and getting them out. When you're not able to do that, you end up with mucus plugging. And this slide just says that there's really no good test. So it really falls on the patient to tell their physician, listen, my cough is not as strong as it used to be. But as you can see, the airway, it's huge. The small bronchioles are very tiny, and in order to clear them is not that easy. We talked about mucus plugging. You can have atelectasis. This can lead to infection and pneumonia. This is what mucus plugging looks like. On the left is a clear open lung. On the right, or in the middle, you have a mucus plug. On the right side, it's a further out mucus plug. The middle one is a larger one. The right one is a smaller one. And this is what it looks like. So a smaller mucus plug can plug up just part of your lung, and that whole part becomes collapsed. A very large mucus plug can block up an entire lung. And, it's important to keep these clear, because as you can imagine, someone with this x-ray is not going to breathe as well as someone who's got both lungs functioning well. How do we treat or how do we make sure that these patients are clearing their secretions? There's a few devices out there that we can give you. Number one is something called a vest device, which is basically a device that you wear that percusses your back, and it helps keep the secretions loose, and it helps bring up I am running out of time, aren't I? Oh boy, I'm sorry, Kenny. I'm going to rush through this. It helps bring up the secretions. The second device is what's called a cough assist. It's a mask that you wear that will force you to cough. It'll strengthen your cough and takes your own cough and makes it stronger, forces you to cough it out. The third device is a newer device called a Valera, which is a nebulizer that vibrates as it's giving you the nebulization, and it helps loosen all the secretions and brings them up. All right, next, the other problem, scoliosis. Scoliosis, although it does, as we mentioned, affect hips, affects your walking, affects your legs, for me, it also affects your breathing. And so, I'm not saying children need to get spinal correction right away, but I always recommend spinal correction before it becomes too severe, because as your spine is crooked, you can see it impedes on your lung. That lung that's being affected hardens in that shape. It becomes smaller and it does stiffen up, and it makes it much more difficult to breathe. So the earlier correction of this, the less likely your lung is going to harden in that smaller shape. Now, it's important to know that in general, if your breathing function becomes severely abnormal due to scoliosis, correcting the scoliosis will correct your breathing, your numbers slightly. They will not change. No study has shown that it changes how you feel clinically. So that's why I recommend the earlier you do it, the earlier you correct severe scoliosis, the better it is for your breathing. Because if you start having severe respiratory issues from it, even correcting your scoliosis is not going to fix that problem too well. I think it was already shown, but this is what, scoliosis correction looks like. And then you can see the third picture there, the lungs are much better inflated. This one is more for kids, so I'm going to very quickly go through this. Vocal cord dysfunction. You can have vocal cord dysfunction in CMT because, again, nerves innervate your vocal cords. You can have bilateral paralysis of your vocal cords or unilateral paralysis. More likely than not, it's unilateral, and most people don't even know about it because it doesn't really affect them. Oh, boy. But basically, in bilateral paralysis, you're going to need something like a tracheostomy. In unilateral, there are, if you're asymptomatic, we leave it alone. Now there are Botox injections that we can give, which help with unilateral paralysis. And then finally, very quickly, because this is the biggest thing that affects CMT, is your sleeping, sleep apnea. Most patients with CMT have sleep apnea. You can have either obstructive sleep apnea or central sleep apnea. And this is key. A lot of patients will have obstructive sleep apnea and they snore. Their wife or husband will come in and say they snore all night. And then all of a sudden they go, oh, you know what? The snoring has stopped. They don't have sleep apnea anymore. Well, no, it may be that you're going from an obstructive sleep apnea to a more central sleep apnea, where you may not snore, but you still have sleep apnea. In these patients, just like any other sleep apnea patient, CPAP is sufficient as long as you don't have any other respiratory issues. In central sleep apnea, CPAP is also not the treatment of choice. It's either BiPAP or more. So if you have either central sleep apnea or sleep apnea and any respiratory dysfunction at all, my strongest comment up here is please do not waste time with CPAP. Go to either BiPAP or non-invasive ventilation. You may also hear the term AVAPs, which is part of all of that. And I will end there so I can give Kenny a chance to talk. And again, you can go through my slides. I think this is being recorded. You can, look at everything. I'm going to leave you with this slide here. I recommend if you have CMT, always go to a center that treats neuromuscular disease. It's very, very important. If you have any respiratory issues, go to a pulmonologist that knows how to manage respiratory dysfunction in neuromuscular disease and specifically CMT. There aren't that many around, and I'll admittedly, let you know that. So the last slide this is my contact information, and I think everyone here will vouch for me. If you call my office, find my email me, or email the CMT Association, they'll get it to me. I try my best to answer all the questions. Now, I get hundreds, sometimes thousands of questions, so the questions may take some time for me to answer them, but eventually I will get to it. All right. Thank you very much. More importantly than me, I have to let Kenny speak because all of my training and everything else I've done with CMT, I am still in awe at how much more Kenny knows about this topic than I do. And I'll let Kenny speak for himself, but just if he doesn't brag for himself, he has a bunch of videos out there. He has a bunch of articles. And although my name may be on some of these articles, I promise you he's done most of the work on these articles. Read them, watch the videos, and he's amazing. So Kenny.
So real quick while they get the slides going, my name's Kenny. Many of you probably know me from Facebook. You've seen me floating around. You've seen some of my breathing stuff. We've conversed about breathing on social media, in email, in person. I have 1A. I was diagnosed at 29, although my symptoms go back to early childhood. I'm a breathing patient. Part of my knowledge base with breathing and CMT is compliments of this guy here, and being a patient and navigating getting care for my breathing and getting my breathing under control. Am I on the board? How do I work this? I'm technology impaired. Green button. That one? That green button. I know, right? I have an aversion to green. Ask the people I work with. If I leave you with nothing else today, consider this question. Is it exercise-induced asthma, or is it a reduction in the ability to increase tidal volume with periods of increased respiratory demand? That's a big word salad. But what does this mean? When I was a teenager, one of my doctors, when I was going through the diagnostic odyssey that so many of us know all too well, suggested I might have asthma. They suggested I might have asthma because I couldn't run with my peers. I was constantly out of breath. I could not keep up. Doctor says, you must have asthma. Here, take this inhaler. It'll help. Take the inhaler before you start doing exercise. Take it before physical activity, take it before gym class. It did absolutely nothing for me. I forgot about it. I forgot about it until I read on my chart chronic neuromuscular related respiratory failure. It all came back to me. I had already learned from Dr. Elsayegh why this might be an important factor. So the breathing we see with CMT is related to muscle weakness. It's not related to our lungs. In CMT, so long as we don't have lung disease, our issue resides with the muscles used for breathing. And although the diaphragm is arguably the most important muscle used for breathing, there's other muscles involved. Muscles of our rib cage, the intercostal muscles, are important for expanding the chest cavity, raising the chest cavity, because if we can't expand and lift the chest cavity, we can't create the volume within the chest cavity for our lungs to inflate. So often, while there is diaphragm weakness, we also have rib cage muscle weakness, or the intercostals become weakened. So if we can't expand our chest cavity, we can't get a full enough breath. Now, on a pulmonary function test, this might look like what we call restrictive lung disease. Restrictive lung disease is a restriction to airflow into the lungs, as opposed to, and this is an important part with the slide on the screen, obstructive pulmonary disease, or an obstructive lung pattern, which is an obstruction to airflow out of the chest. What is asthma? Asthma is an obstruction to airflow out of the lungs. As a CMT patient, although I wasn't diagnosed yet, I was told I have exercise-induced asthma. Hit the inhaler, which is designed to open up the airways in the lungs, is designed to treat that obstructive pattern going on inside the lungs. No effect, because my lungs were fine. We just didn't know that my lungs were fine, that my issues were actually muscle weakness until many years later. So getting this recognized, getting this diagnosed with a neuromuscular pulmonologist, then led to treatment. What led me to the neuromuscular pulmonologist? Who snores? Show of hands. Who in here snores? My wife went to my CMT clinic appointment with me, told my doctor to get my snoring under control. Said I was a champion snorer, I could wake up the neighborhood. That led me to a sleep study. That sleep study led me to CPAP. Who in here is on a CPAP? Who in here has difficulty breathing against that constant pressure of the CPAP? No, just me? No, there's a few. The blinding lights. It's like being on stage when you're at a band, you can't see past the lights. So I couldn't breathe against the pressure of the CPAP, that constant pressure that never changed. Then I learned, wait a minute, that's actually common in neuromuscular patients who have sleep apnea. So I communicate this with my doctor. Oh, well, this is interesting. Maybe this isn't the right device for you. Let's come in, let's do some more study. Let's look at this harder. And we did another sleep study. Sleep study showed that not only did I have hardcore sleep apnea with more than 50 apnea events an hour, but the CPAP was making it worse. It was increasing my apnea events. So as they start to do all their stuff, and I won't get into all the technical stuff today, it's not the purpose, we showed that my metrics from the sleep study, from pulmonary function testing, showed I had muscle weakness. Specifically, they did testing laying down. Who's had pulmonary function testing in here? How many have had a set of tests during that called spirometry while laying flat? And of those who have, did that show any difference when compared to when sitting up doing your tests? Which is an indicator of neuromuscular weakness. The way we treat this, as Dr. Elsayegh talked about, is non-invasive ventilation. So I was moved from CPAP to something with volume pressure or volume support. I almost said volume pressure support. He was about to jump up and hit me. So CPAP and BiPAP are just constant pressure. I'd probably need to speed up. We add volume support. Volume support provides a constant, well, not a constant because it can change with some machines, but provides a volume of air consistent to tidal volume, and that's why that one was on the screen. What's tidal volume? Tidal volume is the amount of air we need to breathe with each respiratory cycle to keep the body properly oxygenated. The respiratory cycle is just simply one breath in, one breath out. Providing that volume support helps the muscles to more fully inflate the lungs with each breath, and it gives the muscles a much needed break. Doesn't turn the muscles off, but it gives them an assistive break so that we can breathe easier, which means there's less muscle fatigue. Once I was on this machine and we had it dialed in, which takes constant communication with your provider team, once it was dialed in, my quality of life improved exponentially, which is probably the overarching theme. When you can have these conversations about what the nature is of your breathing issues in CMT, it leads to getting your breathing under control. Part of this conversation is just understanding or knowing or being able to communicate that our issues might not be with our lungs. The issues with the muscles. And if we can understand that the issues are with the muscles, it leads us to getting it under control. So just as the muscles of the feet and hands can become weakened in CMT, so too can the muscles used for breathing. Dr. Elsayegh talked a lot about diaphragm, and I mentioned the intercostals. Quick little exercise, then I'll wrap up. Everybody put their hands on their chest, because this isn't something we ever think about. Take a nice, slow, deep breath in, and then breathe back out. How many felt your chest move? That's not the diaphragm doing that. That's our chest muscles. That's the intercostal muscles, which there's many. They're all innervated by different nerves, which is an advantage many muscles have the diaphragm does not have. Many muscles, if not most, are innervated by several different nerves. That means they're controlled by several different nerves. The diaphragm's controlled by one nerve and one nerve only, and that's the phrenic nerve. So when the phrenic nerve is impacted in CMT, the diaphragm doesn't have anything else to fall back on the way some of the other muscles might have. So that's why it can become an issue in CMT, not that it will. Also part of the muscles used for breathing are the vocal cords. When the vocal cords weaken, that can impact breathing. That can make other muscles work harder. That brings in muscle fatigue, which can then impact breathing. Also, the trapezius muscle, this big giant thing between our shoulder blades, starts at the top of the neck, comes down like this, like a trapezoid. That can become weakened in CMT. And when it does, that can impact breathing because that muscle is used for lifting the top of the chest so that we can expand our chest cavity the way we need to get a full breath. Thanks for leaving. I love talking about the intercostals. So having CMT does not mean you will have breathing problems, and I cannot stress this enough. While CMT can involve breathing, it doesn't mean it will. Most of us who have CMT will never have breathing problems, and this is very important. I don't want to scare people. I don't want to worry people. But CMT can affect breathing. When you have CMT and you have breathing issues, does not mean they're caused by CMT, and it's critically important to work with your care team to make sure nothing's being overlooked. Because what we don't want to do is just automatically attribute everything to CMT when we have an underlying lung disease. That if we leave the lung disease alone or ignore it, it leads to very severe lung disease that can't be treated well, can't be treated fully, or just completely wrecks our quality of life. As with anything, the sooner we can start treating, the sooner we can start managing and getting under control, the better our quality of life. If nothing else, communicate with your care team. When you tell them you have breathing problems, they tell you everything is fine. Maybe it's not fine. Trust your instincts. Trust what your system's telling you. Trust what your body's telling you. And don't stop communicating. Find a neuromuscular respiratory therapist or a neuromuscular pulmonologist. Who's a neuromuscular pulmonologist? As Dr. Elsayegh explained, a neuromuscular pulmonologist is a pulmonologist who specializes in the respiratory care of neuromuscular patients. They're the ones who can recognize the nuances neuromuscular disease may place on the respiratory system. If you don't have one available, communicate the muscle weakness aspects to your pulmonology team. Let them know that it may not be just your lungs, or that it may not even be your lungs. If you have any questions for me, that's my last slide. Email me, Kenny at CMTA-USA, CMTA-USA.org. Look for our breathing page. Find me on Facebook. Catch me in the halls. Never hesitate to reach out.
Thank you. Incredible presentation. We get questions all the time from community members about breathing-related issues, so that was so valuable. So we're officially running behind, and so what I've decided to do as the time police is we're going to take one question from in the room and one question from Zoom. So is there a mic back there, Gentry? Okay, here we go. So Sarah Cater or whoever's on Zoom, if you want to ask one question.
Hi. So the question from the community is, can cramps or spasms in my ribs be because of my diaphragm? And how can I stop those spasms?
So, yes. So a lot of neuromuscular disease can result in muscle spasms and muscle cramps in your legs, in your hands. Just like those muscles are affected by spasm, you can have intercostal muscle spasms. You can also have diaphragm muscle spasms. Generally, they hurt very much. There are medications to help the muscle spasms to ease them up a little bit. They can cause shortness of breath as well. As you can imagine, just anything in your chest spasming will cause chest pain and shortness of breath. So yes, again, with CMT, it's not very common, but it can occur.
Thank you very much. And I'm going to take one question in the room. First hand. Okay.
Thank you. So I have a question. Lately, I've been drinking coffee. It's been like going down the wrong tube. It's kind of weird. But I start coughing really bad. And then I know that night when I try to sleep, I can't breathe. And I'm just wondering, is that the muscles or the diaphragm or what could cause that?
So I'm sorry, clarify the question again. When you're drinking coffee, is it you're just drinking coffee and nothing happens, or you drink coffee and you're choking on it, coughing after you drink it?
I mean, I'll be like watching some news and I'll laugh or something, and it'll like just go down the wrong tube, and I'll start coughing, like I'll have a real bad cough spell for 5 minutes where I'm just coughing.
So that question is, the answer is not as simple to answer, because you could be describing two different things. Number one, drinking any liquid going down the wrong tube is a sign that you may have vocal cord weakness. Okay, and you have to be careful of that. Or if you have unilateral, which is more likely because you're here not having any issues, it's very unlikely you have bilateral vocal cord weakness. But if you have unilateral vocal cord weakness, the main problem with that is microaspiration. It's just that as you're drinking liquid, some of the aspirate goes into, or the liquid goes into the lung. Things that are very acidic, such as coffee, obviously are more painful and more damaging than less acidic stuff into your lung. But so that's number one, is you have to be careful of vocal cord dysfunction. Number two is if you aspirate enough of anything, and if this is happening without you realizing it, just microaspirations, it can either form infection or pneumonitis, an inflammation in the lung. And that may be why it makes it more difficult to breathe when you're sleeping. So my recommendation is if you're noticing that a lot, that I would check your vocal cords.
Thank you.
You said no more questions, but I think this gentleman really wanted to ask a question over here.
Okay, I'm a rule breaker too, Dr. Elsayegh.
Sorry. He's been trying.
Yeah. I have scoliosis. I snore. My Thank you. Something on my finger. And then she told me that there were numerous events in which I was not breathing. So she put me on oxygen.
Okay.
So my question is that CMT or a pulmonary problem?
Okay. So the thing on your finger is most likely a pulse oximeter. And
Yes.
what it's measuring is your oxygen saturation while you're sleeping. Anyone, forget CMT, anyone with any sleep apnea. Apnea just means you stop breathing while you're sleeping. During that period, your oxygen will also drop. The treatment for that is not giving oxygen. You're not treating the sleep apnea. All you're doing is fixing a number. The treatment for that is you have to treat the underlying problem, which is the sleep apnea. In your case, again, I don't know your history and you may have other pulmonary issues, but in your case, from what you're describing, this sounds to me more like a sleep apnea issue, which more likely than not related to your CMT. And I would treat this with either a CPAP, BiPAP, and in Kenny's case, even higher than that, with a non-invasive ventilator. I would not just treat a number with the oxygen. In fact, I mean, in you, again, you look fine to me, but if you have significant breathing issues with neuromuscular disease, including CMT, the problem is your carbon dioxide level goes up. Taking too much oxygen will increase your carbon dioxide level even more. It makes things worse, not better.
Thank you.
Thank you so much. So that is officially the last question. Thank you all so much. This is an incredibly important conversation. Thank you.